morning. And later on, my colleagues, Dr. Lucas Cheney, the Deputy Director of Spectrum, and Catherine Pilcher, I don't forget your name, don't worry. Catherine Pilcher, our Associate Director, will be the co-host. So I begin today by acknowledging the traditional custodians of the land on which we meet today and pay my respects to elders past, present, and emerging, and acknowledge any first Australians who may be with us today. I also acknowledge people with lived experience of emotional distress, trauma, neurodiversity, and mental challenges, their family and carers, and supporters. I also acknowledge the mental health workforce, consumer care clinicians, for the important work they do. Once again, a very warm welcome to all of you here at the Melbourne Convention Centre, as well as online. It's also my great privilege to extend a special welcome to our speakers today, our lived experience colleagues, Rita Brown, Jacinta Emery, Trish Fitzpatrick, and Chloe Chan. We also have Professor Lois Choi Kain from USA. She'll be streaming online. And Professor Josephine Beatson is here. And Professor Loyola McLean will stream from Sydney. And we also have Dr. Nitin Dawadka and my Spectrum colleagues, Lucas Cheney and Sarah Bellis. You might be wondering why we chose this topic for the conference this year. So as you're aware, although complex PTSD was proposed by Judith Herman nearly 30 years ago, only now it has attained recognition in the classificatory system as an official diagnosis in ICD-11, proposing complex PTSD as a distinctly different diagnosis. So until now, in the absence of the official status for complex PTSD, people with the complex PTSD syndrome would either get a diagnosis of borderline personality disorder or PTSD or both, and treated as such perhaps. This probably contributed to a less nuanced clinical formulation and treatment approach. It's clearly a welcome development, and as it gives us more opportunity to better understand, better research the clinical manifestations of individuals who have experienced complex traumatization. However, we've also seen an unfortunate trend with people replacing a diagnosis of borderline personality disorder with complex post-traumatic stress disorder. Also, clinicians and consumers at times advocating that we rename borderline personality disorder as complex post-traumatic stress disorder, as though both these conditions were one and the same. This has been criticized in some quarters as being unscientific and at times confusing. The problem that I am deeply concerned is that it can invalidate those people with the lived experience of borderline personality disorder, who have lived with the diagnosis of borderline personality disorder and have received and accessed treatments for the same. So we wanted to have a conference to tease out these dilemmas between these two conditions. Now, we know that the prevalence of post-traumatic stress disorder in PPD samples can range from 30 to 60%, and the prevalence of borderline personality disorder in PTSD samples is reported around 35%. So there's a lot of co-occurrence happening here. And borderline personality disorder, PTSD, and complex PTSD can all co-occur. And complex PTSD can coexist with approximately 50% of women diagnosed with borderline personality disorder, and BPD coexists with about 8% of those diagnosed with complex PTSD. So you know that the complex PTSD diagnosis requires, in addition to post-traumatic stress disorder, the additional criteria of disturbance of self-organization characterized by emotional dysregulation, interpersonal difficulties, and negative self-concept. Of course, we'll be talking about all of this in detail right through the day. So these three symptoms, as you can see, can overlap between both borderline personality disorder and complex PTSD. However, it is now clear in BPD science that trauma is very common in people with borderline personality disorder, but not essential for causation of BPD. At Spectrum, more than 90% of people accessing services have had severe and complex childhood trauma experiences, and about 75% of them have a diagnosis of PTSD as well. In the last 23 years, we have provided mainly BPD-specific treatments that are trauma-informed. Fortunately, in our hands, about 80% of people achieve remission from both BPD as well as PTSD symptoms. So our observation is that 20% of the people who could not benefit significantly from our treatments are probably those with coexisting complex PTSD who may require much more elaborate, much more specific exposure treatments for trauma. So how can clinicians navigate the diagnostic and treatment challenges of BPD and complex PTSD? Our speakers today will help us better comprehend this question. A few housekeeping matters. We are requesting that you don't photograph or video record the presentations because they'll be made available for you to watch at a later date. Can I also now request all of you to put your phones on mute and if you have any other devices, put them on the silent mode. And if you have any questions for presenters, please use the chat function. And for our in-person attendees, there is a QR code on your program. Enter the password Spectrum 2022. Our Twitter is hashtag Spectrum 2022. A word of caution, some of the content can cause distress to some of us. So can you please contact one of our Spectrum staff if you would like to talk to us, and look for the Ask Me badge. Now, it is my honor to welcome Dr. Lois Choi from USA. Dr. Lois Choi is the director of Gunderson Personality Disorder Institute. The Gunderson Institute provides training and supervision for numerous proven treatments. And with a mentor, the late John Gunderson, Dr. Choi developed the training program for GPM and has been expanding its applications. Dr. Choi is a global expert on personality disorders and an eminent leader in the field. Dr. Choi works nationally and internationally to expand teaching efforts on borderline personality disorder and its evidence-based treatments. And she engages in research to study resources for training clinicians who need direction and patients who need access to informed care. We are very fortunate to have Dr. Lois Choi supervise some of our programs at Spectrum. It has been an absolute delight having her share her wisdom with us. Dr. Choi will speak on navigating the nosology of trauma-related disorders and personality disorders. What an excellent topic. So there'll be short questions and answers at the end of her presentation. So please submit your questions as she speaks. Over to you, Lois.
Thank you. Actually, I can hear an echo. Maybe I don't know if I can. There.
Experiencing an echo?
Thank you so much for having me at this very exciting conference where I think it's an opportunity to rethink our approach to trauma-related and borderline personality disorders so that we think in less mutually exclusive or politically argumentative ways and focus more on broadening the tools that clinicians and patients can use to achieve recovery. So I'm just going to start by sharing my disclosures. I have a few for which I receive royalties and payments for consulting. But none of that really influences my work with treating trauma-related and personality disorders. I want to start by stating the obvious, that childhood neglect, maltreatment, and abuse are major risk factors for all psychiatric illnesses. This is data that was actually collected in Australia. It's a wonderful study that really shows increased odd ratios of developing a variety of different disorders when you have childhood sexual abuse. So it goes without saying that any trauma in childhood that's repeated and prolonged will make individuals more vulnerable for psychiatric illness and impede their ability to develop healthy psychological means of coping with stress in life. This is why alcohol use disorders, borderline personality disorder, and psychotic disorders are so elevated amongst this population. And of course, many people with PTSD will have serious symptoms related to re-experiencing their trauma and then trying to avoid all triggers and cues related to that trauma. This is separate than the symptoms of BPD that have more to do with overall personality functioning, that is management of self-esteem and identity, as well as management of relationships, that is how close you get to others and how much support you can receive from them. Importantly, while there is an overlap in the territory that this new diagnostic entity, complex PTSD, covers, it does not cover the entire broad domain that BPD encompasses. So it does not actually include the suicidality, self-harm, paranoia, and other impulsive self-damaging behaviors that are characteristic of BPD. What it does do is it acknowledges importantly that those who have had prolonged, extreme, horrifying forms of trauma throughout one's development are not only going to suffer with symptoms of PTSD, but problems that they broadly call disturbances in self-organization. These features are at the core of personality disorders, that is, emotion regulation difficulties, negative self-concept, and interpersonal problems. But what's important to distinguish is those with BPD have intense and unstable relationships with others, while those with complex PTSD tend to have more of a sense of disconnectedness and lack the vacillations, and they're more stably distant from others out of an experience of their harmfulness. So when we think about BPD, it's important to understand at its basis, it's distinguished by its interpersonal features that I just talked about, but specifically this tendency towards frantic efforts to avoid abandonment by friends and family, as well as what we call splitting, the tendency to either go from extremes of loving and needing someone to absolutely hating and fearing them. And this causes a great deal of disruption to important relationships throughout one's lifetime. These patients come to our attention because of their self-destructive, impulsive behaviors, but these are not the most enduring features of BPD. The broadest features have to do with mood dysregulation, which is transdiagnostically common with a lot of disorders that tend to co-occur with BPD. And lastly, the disturbances in one's sense of self that comes naturally from having such pervasive instability and such difficulty forming a coherent life trajectory and identity over time. That kind of integrity of identity and self really is the vulnerability that defines personality disorders generally and BPD specifically. In contrast, PTSD, including complex PTSD, is characterized by having the history of repeated exposure to trauma, that is childhood sexual abuse or physical abuse, prolonged domestic violence, torture, slavery, concentration camps, and experiences that are extremely terrifying and horrific in nature. While this is a disorder that's just entered the diagnostic nosology of the ICD-11, early studies have shown that its prevalence is significant, on par with other major mental illnesses such as OCD, bipolar disorder, and borderline personality disorder. We know in the general population, borderline personality disorder occurs at about 3% of the US population. And we also know that it is diagnosable in adolescence and has the same degree of prevalence. In the general community, we know that most people with BPD do not have PTSD, but a significant minority, about a third, does. We also know those with PTSD mostly do not have BPD, but about a quarter of them do. So in both populations in the community, these things should be screened out to provide the best care. But when we talk about patients who seek treatment repeatedly, we see different kind of patterns of prevalence. We know that those with BPD have a high utilization of health services, which means they want our help and they seek that help repeatedly in many different settings where we have the opportunity to intervene. This is the prevalence of those with BPD in a variety of clinical settings. And among those inpatients who are seeking care for suicidal ideation, about half of them will meet diagnostic criteria for BPD. And in adolescents in the emergency room with suicidality, a majority of those will meet criteria for BPD. We see this in clinical samples that the rate of PTSD among those with BPD really more than doubles. Similarly, the rate of BPD amongst those who have PTSD in clinical settings also increases appreciably. So these patients who we see in routine clinical practice have a higher likelihood of co-occurrence of both disorders. Studies about complex PTSD are just beginning to enter the literature, so we don't know as much about this, but we estimate that amongst those in clinical settings with BPD, about 45% meet criteria for complex PTSD, which is not a surprise given the prevalence of childhood maltreatment and abuse amongst these patients, which we integrate into individualizing their care. We don't know as much about those who have complex PTSD, and these figures are derived from a study of subjects in clinical trials for PTSD, which we know excludes patients routinely who have significant suicidality. So I think that these figures kind of represent the proportion of patients who typically will have BPD that also meet this diagnostic criteria. Like Sathya was saying, childhood abuse and neglect does increase the risk for personality disorders, but it does not increase the risk for BPD more than any other personality disorder. So this is something that we have to consider, and we have to really recognize that while these things commonly co-occur, they are not mutually exclusive and they cannot substitute for the other diagnosis. This is the outcome from a study done in Italy of people who had experienced trauma. And amongst those patients, there were some patients who had overlapping diagnoses, but many patients who had one of these three diagnostic entities. And they found that there was no significant relationship between a history of trauma and the BPD diagnosis. We also know throughout the literature that trauma is neither necessary nor sufficient a factor for the development of BPD. Many people who struggle with BPD have no history of significant trauma, but it may have the accumulated effects of a significant degree of adversity that's interfered with their developmental opportunities to gain the skills they need to live life more meaningfully. And that is the part that I think needs to be acknowledged. Just because people do not meet criteria for trauma, for a post-traumatic stress disorder or complex PTSD, does not mean they haven't faced a great deal of adversity in their lifetime. So to this question, can complex PTSD be used instead of the diagnosis of BPD? I would emphatically say no. We know enough now in the current state of the scientific research in the field to really be confident that we can distinguish and discern the differences between these disorders, as well as when they co-occur in our patients. And just to help you think about this, I'm going to present the outcomes from a number of studies that look at a population of patients and analyze the natural clustering or grouping of classes of patients within a sample of people who have experienced trauma. The first of these studies was done by Choi, who is a very well-known contributor to the complex PTSD field. She took all the subjects in a number of randomized controlled trials for PTSD treatment. So remember, these trials often exclude those with significant suicidality and self-harm. So oftentimes exclude BPD patients. And what they did was they looked for latent classes within this group, and they found 4 types. And what I want you to notice is that actually a good fifth of these patients had low symptoms over all of the diagnoses considered. And there was a PTSD type, which was about a fourth of patients, a complex PTSD type, which was another fourth, and a BPD type that was a fourth of patients. So all 3 of these diagnostic classes seem to exist in this trauma sample, as well as a group that had low symptomatology overall. And the symptoms that seem to distinguish those with BPD from those with PTSD included the ones that have most to do with personality disorder. That is frantic efforts to avoid abandonment, unstable sense of self, unstable intense relationships, as well as the self-destructive symptoms. This should not be surprising. But when we look at this graphically, what I want you to notice is that if you consider those with BPD in the red, they have the highest burden of symptoms overall of all the 4 classes across PTSD, complex PTSD symptoms, as well as BPD symptoms. When you consider complex PTSD, you see that they actually have a low symptom burden in the BPD area, except for emptiness, which may be related to dissociation. And that is really, I think, something to keep in mind, that those patients who have BPD have more psychiatric symptoms that need treatment and intervention. Another study like this was done by Jowett et al. In a clinical sample. What they did was they studied patients in a clinic treating trauma, and this was not in a randomized controlled trial setting, so it did not exclude patients that were excluded in the Cloyter study. And what they found was a higher prevalence of BPD problems. So there were 3 groups in this study, one with complex PTSD and high BPD. This was almost a half of all their patients. And then another robust part of the sample that had CPTSD as well as moderate BPD. And very small part of this clinic actually had patients who just had PTSD without much in terms of BPD symptoms. That was only 16%. And when you look at their burden of symptoms, again, you see the class that has both complex PTSD and BPD have the highest burden of symptoms. And then those with moderate BPD and complex PTSD. And then you see that those without BPD have a much lower burden of symptoms, but they can be treated for PTSD. And I would argue these patients would respond to PTSD treatments, but PTSD treatments alone are insufficient to help the other patients. This is the last of these studies by Sear et al. That was more recent. And again, they showed that there was a high BPD group, and you see in the blue that they have a higher level symptoms in the BPD realm, as well as the disturbances in self-organization. And there was a group that had high BPD and and complex PTSD. And you see in the red, they have the highest burden of symptoms again. So we have to diagnose both disorders because these patients need more help. And the conclusions we can draw from this is that many traumatized patients will meet the diagnosis of BPD and suffer greater psychiatric burdens. And we have to keep in mind that PTSD treatments do not target these symptoms. So we are going to abandon these patients without acknowledging their BPD and treating it with the treatments that we know work. There are many reasons to treat BPD, the first of which is suicidality. This is what kills people with BPD. Most patients with BPD will engage in some suicidal behavior in their lifetime that really illustrates their degree of psychic pain. And they also engage in self-injurious behavior. While acutely not dangerous, it elevates suicidal risk over time. And the rate of suicide amongst those with BPD is 50 times greater than the general population and comprises a good proportion of completed suicides in both adults and youths. And BPD has enormous costs to those who suffer with it, their families, and the societies they live in. We know the costs are greater than that of depression and anxiety disorders, and similar to something that's chronic, like schizophrenia. And the out-of-pocket costs are significant and unaffordable for most people in the US. I think you have a more organized system there, but still supply will never meet demand in most environments. We also know that having BPD symptoms early increases the likelihood of being unemployed and on disability later. So detecting these symptoms early and intervening to empower people to mitigate the risk for these outcomes is what we can do to help them most. The good news is we know the symptoms of BPD do tend to remit over time. This is the outcome of Mary Zanarini's longitudinal study that shows high degrees of remission from BPD symptoms over time. And we also know from longitudinal studies of use in the community that BPD symptoms can be detected early. And we do think that intervening as soon as they're detected is really important. This is a graph that shows the elevation of BPD symptoms across all use over time. These are symptoms that naturally occur for children as they verge into greater independence in a social environment where there are greater demands and a greater degree of independence from supervision and support from adults. And at first, for most young people, BPD symptoms, emotion dysregulation, impulsivity will increase over time, but throughout the teen years, individuals develop a sense of self and stable ways of relating to others that allow them to gain control over these features, and they tend to naturally decrease over time. Those with BPD are actually detectable early on as having more symptoms of BPD in comparison to their peers. And these symptoms also increase in the same time course, but then stay elevated over time because the degree and severity of the symptomatology interrupts their ability to contain any of the symptoms. And then it ends up segregating these individuals from the developmental trajectories that help people gain a sense of psychological stability. And then this distance that those with BPD experience from their peers contributes to negative self-concept, low self-esteem, and missed opportunities to develop social and emotional capacities that they need to enter the adult world and start to define a life trajectory that's meaningful and stable. We know that there are stressful effects of having BPD early. In longitudinal studies of use that are kind of representative of a community, this is Stephanie Stepp's study, they found that BPD symptoms of impulsivity and negative affectivity predict harsh punishment and low parental warmth. there is a kind of interactive effect where having these traits actually increase risk for certain kinds of parental failures. And then these forms of parental adversity then start to feed into increased risk for BPD in the teen years. So this can become a vicious cycle, but if you can intervene and decrease the BPD symptoms earlier, you can actually short circuit this process. Furthermore, a separate study has been done in Europe that showed that dysregulated behaviors very early in life at the ages of 4 to 8 increase the risk of social adversities such as bullying and harsh parenting that then go on to predict BPD symptoms later at the beginning of adolescence. We also know that BPD affects all realms of functioning. BPD predicts problems at school, both in a disciplinary and academic sense. And those with BPD have over 3 times elevated odds of not advancing beyond high school. And the important note here is that those who achieve remission are more likely to have good school performance than those who do not achieve remission. And these symptoms of self-harm and impulsivity uniquely account for the variance in academic achievement and social maladjustment. Similarly, BPD predicts problems of occupational functioning of all sorts. Those with BPD are less likely to be working 9 years after their diagnosis. They need more help to manage occupational demands and stay on those trajectories. And I think that's where treatments need to focus. And again, remitted patients have a greater likelihood of having satisfying experiences in this realm. BPD also predicts problems in romantic functioning, and these go without saying, but again, improvements in relationship functioning with friendships and family increase with improvements in BPD. So targeting BPD symptoms are important for improving all realms of a person's life who has this disorder. And lastly, BPD predicts problems of physical illness. BPD traits are associated with a broad variety of medical problems that are chronic and compound by causing other downstream effects. And luckily, again, those who remit are less likely to suffer from long-term poor health than those who continue to have BPD. And part of this may be because BPD is a general factor of personality psychopathology that leads to high vulnerability to psychiatric illness, co-occurrence, and persistence. Therefore, treating this is going to help all the other disorders this person has respond to treatment. Furthermore, it is basically a problem of managing oneself and others. And we all need those capabilities to be stable to get us through the challenges we all face in life. So moving on to treatments. The good news is that we know a lot of treatments work for BPD now. And if you look at their mechanism of change, these are treatments that can help anyone. Skills to be more emotionally regulated and effective. Skills to be more stable in your ability to accurately, flexibly, and benevolently understand yourself and others in social interactions. Integrated, balanced, coherent ways of thinking about oneself and others and the interpersonal dynamics in relationships that improves with TFP. And also the corrective experience of getting a life and managing your BPD symptoms so that you can feel good about yourself and you can feel good about your future. That is not toxic to anyone, and this helps a variety of different disorders. The most recent meta-analysis of psychotherapies for BPD tells us that in 31 randomized controlled trials with almost 2,000 participants, that these treatments tend to work in symptom domains that other treatments don't, like suicidality and self-harm, BPD severity, anger, as well as other forms of impulsivity and interpersonal problems. We also know that add-on treatments that are designed for BPD have a broad range of effects that can help most patients, especially those who have experienced trauma. So we do know that improvements in BPD symptoms actually will predict the remission of PTSD, even without treatment for PTSD. And I'm not arguing that you shouldn't treat PTSD, but they have some common effects on mechanisms that may help those who suffer from both disorders. Similarly, PTSD does have to be addressed because ongoing PTSD symptoms will predict the relapse to BPD, meeting criteria for BPD even after remission. So we're going to look at more of this data to really look at how sometimes people with BPD that have PTSD, not complex PTSD, may respond to BPD treatments alone. And some of those patients may need a combined approach. This is data from our treatment center that showed that in the preceding time period, borderline personality disorder symptoms, if they improved, we saw an improvement in PTSD symptoms at the next time point. The other way around was not true. Improvement in PTSD symptoms did not predict improvement in BPD symptoms over time. So we think that if you focus on BPD symptoms first, they're likely to have a stabilizing effect overall on all domains of psychiatric difficulty for patients, and they may put patients in a better place to use the treatments for the co-occurring disorders. We also know from the literature that treatments for BPD, like PTSD, actually help those with PTSD who don't even have BPD. And similarly, those patients who have both disorders are going to have a greater burden of symptoms, like we just talked about. And if you look at this study of DBT, you see that those who complete treatment actually have a very similar trajectory. Those with BPD and PTSD have a higher rate of self-harm than those with BPD alone, but you see a great degree of improvement. But a lot of patients will drop out, and those with PTSD are at higher risk for that, and that's what we have to clinically pay attention to. We also know that DBT can lead to decreases in suicidality and increases in emotion regulation for adolescents, even when they don't meet criteria for BPD. And DBT-informed therapeutic communities lead to increases in clinical gains for those with childhood sexual abuse and decreased PTSD, mood, and interpersonal symptoms in women who have childhood abuse. Lastly, in an MBT program in Europe, they found that when they compared patients with and without trauma, MBT worked equally for both groups. But what they found is those who had more severe trauma and greater emotional neglect actually improved more or improved faster in a more intensive form of treatment in day hospital versus outpatient treatment. And that may be another thing that we may keep in mind for patients who have both disorders. So the punchline is BPD treatments work broadly for patients who have trauma-related disorders because they also involve problems of emotional dysregulation, problems of self, and relationships to others. And this is evidenced by the fact that Cloytre herself developed a treatment to add on to exposure therapy to enhance treatment outcomes for those with complex PTSD. And what she did was an abbreviated form of DBT, as something that preceded and gave patients skills for the exposure part of the treatment. And this was her report that showed actually STARE, this kind of abbreviated DBT plus exposure, had the best outcomes in reduction of PTSD, in reduction of interpersonal problems, and in improvement in emotional regulation. And like I said before, the problem with PTSD treatments alone for those who have BPD and some form of PTSD is that the treatments we know for PTSD have been trialed on samples exclusively including patients who do not have some of the cardinal features of BPD. And so therefore the efficacy of PTSD treatments for those with BPD is unknown. We also know that BPD treatments may not be enough for those who have BPD and a trauma-related disorder. And with those who have both disorders, we have to help them remediate the problems they're facing in their current life circumstances so that they can remoralize to have more positive experiences that increase their motivation to invest in themselves and do things that increase their sense of self-efficacy and broaden their social support network. We should keep in mind those with PTSD may be more vigilant and may face more difficulty becoming attached in therapy. In the treatment guidelines for complex PTSD, they even really strongly note that those with PTSD should always get treatment for their co-occurring disorder. And when we think about these diagnoses as mutually exclusive, we're not actually following the treatment guidelines for complex PTSD, which include directives to treat co-occurring borderline personality disorder. Now, I'm just going to end on the combined treatment of BPD and complex PTSD. Martin Bohas has developed a 42-session treatment that is an outstanding integration of exposure therapy and DBT. And it really combines the best of both worlds, the treatment that helps with the re-experiencing symptoms and the avoidance, as well as the broader personality problems related to BPD. And this was first trialed in a residential setting for safety and feasibility. And then it was subjected to a large randomized controlled trial that included almost 100 subjects in each arm, with the comparator being cognitive processing therapy. And that arm was run by Patty Rezek herself. And these were the patients in this sample were people who had severe childhood sexual abuse, on average 7 years, starting at the age of 7, and had to meet at least 3 BPD criteria. And that at the end of treatment, and with 3 months follow-up, DBT PTSD was superior than PTSD in reducing PTSD symptoms, BPD symptoms, as well as depression. And it also had significantly fewer dropouts. Now, what's involved in this treatment? First of all, a kind of process of commitment. Those with BPD and PTSD have different challenges to wanting to and feeling capable of working on their trauma-related symptoms. They're scary, overwhelming. They induce feelings of powerlessness and fear that anybody would want to avoid. But in order to combat these forces that interrupt treatment, there's a component of psychoeducation that explains how trauma affects one's life to increasingly reduce a person's world over time because of the avoidance and escape mechanisms they use to manage their PTSD symptoms. Then they give the patient skills, DBT skills, to actually manage their emotions and monitor themselves and stay mindful to their experience so that they can decide to do things compatible with their longer term goals. Then a process of exposure is conducted over 12 weeks to really target the symptoms of re-experiencing as well as avoidance. And the idea is, over time with exposure, the patients will learn that they can tolerate and effectively manage their memories of their trauma instead of having intrusive experiences related to those traumatic experiences. And that in seeing themselves manage this effectively with the skills they've gained, they will have a corrective experience and no longer fear and avoid these cues of their trauma as much. And then there's a period of acceptance and grieving that this trauma happened to them and is a part of their life and their life trajectory. But the biggest part here is to construct a new path considering an old path of life was highly dictated by their PTSD. They need to figure out a way to live according to their goals and values moving forward and leave behind the life that was dictated by their symptoms. I'm going to skip this part in the interest of time. So the whole point of this in combating complex PTSD is to move from uncontrollable intrusions to controllable memories. But after the resolution of trauma-related symptoms, personality instability remains. These treatments don't address that sufficiently. And that's where these BPD-related treatments are really most important. And that's why they're longer in duration. Because beyond the BPD symptoms are a need to address their inner core, problems of identity, problems of immature or inadequate coping skills or defense mechanisms, problems of channeling aggression productively, problems of empathy and tact, and problems of unstable relationships. So these treatments are really trying to promote corrective experiences to heal a sense of self, as well as a problem of interpersonal hypersensitivity. In our treatment, we think about interpersonal hypersensitivity as the driver of BPD symptoms. And if you have trauma, of course, you're going to suffer from interpersonal hypersensitivity. So when you're feeling comfortably connected to someone, you may be idealizing of them, think of them in kind of mostly loving terms and be receptive to what they have to say. But inevitably that relationship will disappoint you. And normal disappointments oftentimes are received as real, with a real sense of threat. And in that threatened state, people with BPD will either resort to self-injury or lashing out towards others. And these behaviors tend to be confusing and unmanageable for others and precipitate their withdrawal and their abandonment. And it's then that these patients become truly vulnerable because they're alone and in an alone state, unanchored from the relationships they really depend on. They become more paranoid and more recklessly self-destructive. And it's a lack of holding from an interpersonal environment that leads them to feel like life is not worthwhile and that they would be better off dead. A lot of people will intervene at this point with creating a holding environment, with treatment, hospitalization, or even at sometimes prison, especially for male patients. And the reconstitution of social safety net will bring this person back to feeling stabilized, but this becomes a vicious cycle. And BPD treatments are really focused on trying to lean in during this vacillation in the instability of relationships between idealized and devalued to help patients understand these dynamics differently in a more realistic sense and employ more pro-social behaviors to work things through. And after all, we all need that. So we want people to build their social capital by being more self-reliant, given their interpersonal hypersensitivities, and to try to aim for contributing to the world in a way that they can feel good about. And getting a job or a role in one's community is really important, because depending on yourself and gaining the skills to do so is better than depending on the likes of me as a clinician. And it really conveys a message that you're a person, not just a patient. So we're just really trying to help people think first, develop a corrective relational experience where they recognize people are flawed and limited, but not dangerous all of the time, so that these people can go into the world more with more reassurance that they can get a life that's worth living. Because after all, we need to help these patients achieve love and work, because that's the cornerstone of humanity. We need to incorporate them back into the world where they can develop a life that feels worthwhile. So the clinical implications I won't go over in the interest of time, but I think most importantly, we have to diagnose all the disorders that are relevant to patients and treat them actively. And the BPD treatments may stabilize patients in order to be less psychiatrically vulnerable and more receptive and responsive to other treatments for other disorders. And in the case that you could access a treatment that treats both complex PTSD and BPD, that might be of the highest yield. This was a quote from a patient interviewed in this article in Scientific American on this very debate. And what she said is, what we label this is not the issue. It's finding the solution that is really important to the people who suffer from these disorders. So on that, I thank you for your attention.
Thank you, Lois, for that very insightful presentation. We are running a little late. Probably I'll allow one question. There's a question for you, Lois. Can you hear us?
Yes.
The question is, most of the science of borderline personality disorder that we know is for women with the diagnosis of borderline personality disorder. Is that the same? Is it the same for complex PTSD as well? Do we know much about men who have complex PTSD?
I think because women are more likely to seek treatment in clinical settings, we just have had greater access to studying how these disorders present in females. But I think we need to do more research on males with both BPD and complex PTSD. And I think what we'll find is that their presentation is more outwardly aggressive. And therefore, I think the usual response we have is to try to control their aggression and contain their behavior rather than understand the psychological factors that drive the behaviors as an outcome of a more vulnerable process. So I think that is an important area of further research and treatment development.
So thank you very much, Lois, for that wonderful presentation. You have clearly set the right tone for the rest of the conference for us. Thank you.
Thank you for having me.
I now welcome my colleague, friend, philosopher, guide, Professor Josephine Beatson. Dr. Josephine Beatson is a consultant psychiatrist, a psychoanalytic psychotherapist who has worked in the field of personality disorders over many, many years. She is experienced in mentalization-based therapy, common factors treatment for borderline personality disorder, and particularly interested in the impact of childhood trauma on the phenomenology of borderline personality disorder. She also helped us develop a screening tool for BPD in old age, which was recently published. Professor Beatson has extensive experience in both private and public settings. She has supervised, taught, researched, published widely, and she is regarded as one of the Australia's foremost authorities in the field. She has taught a generation of psychiatrists, including me. She was the recipient of the college citation from the College of Psychiatrists in 2020. She is an absolute legend. So please submit any questions you might have for Professor Beatson. Over to you, Joe.
Well, thank you for that overly flattering speech. I'll stuck that there in case I need it. Okay. Is the sound okay? Can everyone hear? Yeah, okay. I'm going to talk today about psychic trauma and its history in psychiatry. Now, findings about the effects of trauma on the human mind have been made and then forgotten repeatedly since the late 19th century. We're going to look at developments over that period and reflect on what these repeated forgettings reveal about society, politics, and psychiatry. Trauma's effects on the psyche, of course, have been known for centuries, in fact, throughout history. Homer, Shakespeare, Virginia Woolf all gave vivid descriptions of post-traumatic symptoms. one of the earliest reports is from an Assyrian warrior in 1300 BC who experienced visual images, nightmares, hypnopompic hallucinations of dead enemy soldiers, and he experienced those when awoken from a dream, together with depression and memory problems. In that day, his symptoms were attributed to the vengeful spirits of enemies killed in battle. Lady Percy, in Shakespeare's Henry IV, gives an extremely vivid description of the post-traumatic symptoms her husband suffered after a major battle. Sleep disturbance, startle reactions, vivid flashbacks of soldiers slain, and all the currents of a heady fight, writes Shakespeare. Psychiatry really only began to explore these symptoms in 19th century France, mainly at the Salpêtrière under Charcot. Freud and Janet both studied there, especially studied the so-called hysterical phenomena. We would now, I think, describe them as conversion symptoms that they witnessed at that Salpêtrière. Both initially believed that childhood sexual abuse was the source of these phenomena. In 1896, Freud wrote, "A precocious experience of sexual relations resulting from sexual abuse committed by another person is the specific cause of hysteria." He presented his paper, The Etiology of Hysteria, in 1896 to an Austrian audience. He expected adulation, but he received silence and outrage. 5 days later, he wrote to Fleiss, his friend, who was an ENT specialist in Berlin, I quote, "A lecture on the etiology of hysteria met with an icy reception, and this after one has demonstrated to them a solution to a more than 1,000-year problem, a source of the Nile." Distressed and outcast, Freud developed his theory of the function of repressed early sexual fantasies, PH fantasies, you notice, for unconscious fantasies, and the Oedipus complex as well in the origin of hysteria. Repression displaced dissociation in psychoanalytic thinking and indeed in psychiatry thinking over the next 80 years. Freud's theory was duly adopted by the psychoanalytic community, and the so-called seduction theory of hysteria disappeared from Freud's writings. Now, the reality and effects of childhood sexual abuse did not reappear in the literature until the 1970s and 1980s, 80 plus years, in other words. And they came back with the work of Judith Herman and others, as I will talk about later. Now, this prolonged forgetting can be attributed to several factors, I think. The subservient role of women in society, really, I suppose, until, again, the advance of feminism. Society turning a blind eye to what it doesn't want to see. And the use of defences of denial, repression, suppression, dissociation, and identification with the aggressor. Now, in this case, of course, the aggressor was Freud. He was so prominent. He was so, I suppose, idealised by the psychoanalytic community that they took on his views. It is only too apparent that societal and political factors greatly affect what people, including psychiatrists, are willing to countenance. We will see more and more evidence of this as we go on. But it's striking that only Ferenczi, among the psychoanalysts of the early 1900s, recognised the reality of childhood sexual abuse, and he was duly ostracised for it. Other analysts reacted with embarrassment to his writings, which remained unpublished until many years later. Now we turn to World War I, which forced awareness of psychological trauma back into the zeitgeist, if you like, at the time, via the study of shell shock. It was initially thought to be due to a molecular commotion in the brain. I rather like that definition, actually. Myers, a psychiatrist and captain in the Royal Army Medical Corps, made a careful study of the soldiers' experience in the trenches. He described shell shock in the Lancet in 1915, and the three people he described had had horrendous experiences. Shells bursting around him when hooked by a barbed wire fence and unable to escape, in one case. The trench blown in by a shell and temporarily burying the second soldier, and the third one was blown off the wall of the trench by the shell. All three experienced reduced visual fields, reduced taste and smell. Two experienced distinct amnesia for the events. All, thankfully, improved gradually with rest, suggestion, and in one case, hypnosis was needed. Shell shock, oh, I've said that, okay. Now this was followed by Myers, good clinician that he was, recognition that shell shock could occur in men who had never experienced shells bursting around them, bullets and so on. And it could be a result of terror. This was, of course, not at all well received. British soldiers were meant to be heroes, not ordinary human beings, traumatised by the shells and the rats and the mud and the horror of the trenches. And you'll note that image, the soldier on the right on the left, has what was called the 1,000-yard stare, a frequent symptom of shell shock. But forgetting followed, really, through and before the end of the First World War and after. Sorry, not before, after. It would have been better for the soldiers if molecular commotion in the brain had remained the explanation. Soldiers with shell shock were now often seen as cowards, premorbidly vulnerable, simulating symptoms to get compensation. Victims were devalued and their suffering ignored. Politicians who had led Britain into the Great War didn't want to take responsibility for the carnage that occurred. Again, rationalisation, denial, repression, turning a blind eye to the loss of life, limb and mind, together again with identification with the aggressor prevailed. The aggressor in this case being the politicians and the heads of the armed forces that had led the country into war. Siegfried Sassoon, pictured there in that lovely image, wrote, he was one of the war poets, of course, shell shock, how many a brief bombardment had its long delayed after effect in the mind of these survivors. Not then was their evil hour, but now in the sweating suffocation of nightmare, in paralysis of limbs, in a stammering of dislocated speech. In the name of civilization, these soldiers had been martyred, and it remained for civilization to prove that their martyrdom was not a dirty swindle. Then psychological trauma largely disappeared from the scene until World War II broke out in 1939. When it first broke out, the term was outlawed in Britain. War pensions were denied for psychiatric injury. These injuries were labelled exhaustion and seen as recovering naturally with rest and respite. After Dunkirk, though, it was gradually accepted that even elite soldiers exposed to trauma, and protracted trauma in particular, could break down. Yet again, after World War II, the memory of war trauma was again largely forgotten until the Vietnam War. Psychiatrist Abram Gardner had treated US war veterans in World War I, and he was the first to recognise the psychological and physiological reactions to traumatic stress. He defined the phenomenology very carefully in an epic work, The Traumatic Neuroses of War, which was published in 1941, you notice, shortly after the outbreak of World War II. And he, in that book, stressed that flashbacks and other symptoms could persist long after the original trauma. Not that nothing was remembered from World War II, just briefly as an aside, research on protective factors for soldiers at the front showed the benefits of training and group cohesion and leadership, and retrospective research after World War II led to the deployment of psychiatric teams in the Korean War. And group therapy was developed by Wilfred Bion, psychoanalyst, very famous psychoanalyst, who is depicted there in his army uniform. But DSM-1 and DSM-2 still formulated combat stress reactions as short-lived in the absence of pre-existing vulnerability. Then came the Vietnam War. American troops had been dispatched to, or were dispatched to Vietnam in 1965, and when they began to return, and particularly after 1975, it was recognised that delayed stress-related symptoms occurred in those soldiers, which refuted both DSM-1 and DSM-2. Work towards DSM-3 began, and the Vietnam vets and the psychiatrists and the psychologists who treated them drove political activity to enforce government awareness and response to their suffering. The vets would not be silenced, and it was their refusal to stay silent and the actions of the mental health professionals who supported them that drove the US government eventually, somewhat reluctantly, to finance comprehensive services for the war veterans. And then DSM-3 was duly published in 1980, and Gardner's findings were enormously used in the criteria they put in there. So was Horowitz's work on the stress response syndrome, and findings, note, from just 200 Vietnam vets. Wouldn't get away with it now in a diagnostic categorisation. But there remained a persistent disjunction in all this. Janet, Myers and Gardner all recognised the role of dissociation in post-traumatic symptoms. The PTSD working group for DSM-3 was unaware of the existence of a dissociation working group working towards a diagnostic system for dissociative disorders in DSM-3. Recommendations were made, finally, to combine the two groups, but tabled by DSM until recently in DSM-5. There's some recognition of the importance of dissociation. That disjunction, that separation between psychiatry and the work of people who were general psychiatrists, you might say, and the work of the trauma specialists who were often psychologists, not psychiatrists, but they seemed to be more aware of the clinical features of their patients who had been traumatised. They all stressed its importance. And I think that really held back psychiatry's understanding of the effects of trauma for a long time. After DSM-3, research on PTSD absolutely blossomed. Prospective studies showed that vulnerability can play a role in the development and its outcome. It was accepted, finally, that PTSD could follow any significant trauma, not just combat, and high stress levels over a long period were shown to have the capacity to lead to breakdown even in the strongest person. Sharlef and Mama, who are very well known in the field of trauma, write, quote, "The extent to which PTSD is the proper descriptor of the consequences of traumatic events has been fiercely debated. Nonetheless, its inclusion in DSM-3 was a formative step in the recent history of mental trauma in psychiatry. It structured clinical observations, created much-needed consistency in diagnostic criteria, and provided a necessary condition for empirical research. Its inclusion, nevertheless, met huge opposition. The Veterans Administration responded to a research submission from Van der Kolk, of course one of the greats of the field of trauma. This was their response. It has never been demonstrated that the diagnosis PTSD is relevant to the mission of the Veterans Administration. This in spite of epidemiological research which showed that 15.2% of male Vietnam vets suffered PTSD almost 20 years after the war. So, enormous progress, as Charles and Mama have noted. Thousands of scientific papers of increasing rigour and complexity emerge on psychic trauma each year. Huge growth in knowledge of the neurobiological effects of trauma have been published. Effective treatments have been developed. I'm often left wondering, where is the individual patient in all this? We mustn't lose sight of the bigger picture while we endeavour to list every symptom of PTSD. The bigger picture is more than an exhaustive list of symptoms or more findings on the neurobiology of trauma. The bigger picture, as Lois has so well demonstrated, involves a human being for whom the meaning of the trauma and its effects on their relationships and indeed on their lives is what matters. In the light of DSM-4, and the trial version and the DSM-5, is it time to return to the core symptoms of post-traumatic states of mind, known for centuries, and consider other aspects of trauma, and consider the comorbid conditions that so often arise? ICD, thankfully, offers just 3 core areas to define it: re-experiencing the event, avoidance, and persistent sense of heightened threat and significant impairment in functioning in important ways. I just note that the agreement between the DSM-4 and 5 versions of PTSD is massive. 45% of vets who met DSM-4 criteria for PTSD didn't meet DSM-5 in one study. So it's time really to focus away from exhaustive, I would say, obsessional search to include every symptom in the book, of which there are hundreds, to focus again on the meaning of the trauma and the impact on the victim's life, and the cultural and social attitudes that affect the response to trauma, including the attitudes of people just like us, clinicians in the mental health field. Now, turning to a terribly important topic, the role of trauma in the lives of women and children. The forgettings about this, as I've said, really occurred for over 80 years. And the growth of psychoanalysis, I'm very sad to say, in Europe and the US overran Janet's findings on the role of childhood trauma in hysteria. Van der Kolk, again, a wonderful psychiatrist working in the field, reports his endeavours to investigate incest in the psychiatric literature when he started work in Massachusetts in 1982. He first looked at Friedman and Kaplan. Many will know that Friedman and Kaplan, very esteemed and grand book, psychiatric, comprehensive textbook of psychiatry is its proper title. It stated as follows: incest is extremely rare and does not occur in more than 1 in a million people. Van der Kolk calculated that meant that of the 100 million people, women, not people, women, living in the US at that time, 47, almost half of them, had somehow or another found their way to his basement office in Massachusetts. So, the work of Judith Herman and other feminists changed everything in that regard. Her papers, Judith Herman's papers, on father-daughter incest and childhood trauma in borderline personality disorder led the way. Burgess and Holstrom, in due course, identified rape trauma syndrome in the 1970s. Herman's book, Trauma and Recovery, advocated, of course, the new diagnosis then, complex PTSD, to cover the effects of chronic inescapable trauma. She listed alterations as, well, Lois has said all this, but just for to repeat, alterations in affect regulation, alterations in consciousness, self-perception, perception of the perpetrator, relations with others, and systems of meaning. And I really like the list she made in that book of the following examples of subjection, of what could lead rather to complex PTSD. Subjection to totalitarian control over a prolonged period, months or years. Experienced by, for example, hostages, prisoners of war, concentration camp survivors, those subjected to totalitarian systems in sexual and domestic life, including battered wives, childhood sexual or physical abuse, and organised sexual exploitation. But there's more to trauma than criteria, as I think we are all hopefully well aware. The Adverse Childhood Experience Studies in 1998 revealed the shocking effects of adverse childhood experiences on adult mental and physical health. They certainly recognised the effects of disorganised attachment on emotional development in childhood, and they've contributed enormously to our understanding of the importance of childhood experience on emotional development and the crucial importance of doing all we can to recognise when things are going badly for a child, and as a society doing something about it. Now, you will have noticed that the lowest level on the pyramid shown there refers to generational embodiment of historical trauma. Now, that is just what the Aboriginal and Torres Strait Island people in Australia have experienced. That is the foundation upon which the cumulative effects of later adversity have grown since the arrival of the First Fleet in Australia in 1788. As Lois has said, CPTSD was included in ICD-11 in 2019, and I won't repeat the features of it because she has done them so beautifully. Like the impact of naming and specifying the criteria for PTSD in DSM-3, the naming and specifying criteria for complex PTSD is of enormous importance. There's been an amazing burgeoning of research validating the criteria and the beginnings of randomised controlled trials on psychological treatments. And most importantly, the diagnosis captures the profound, absolutely profound impact of repeated inescapable trauma in childhood and in adult life as well. Well, I feel I'm repeating myself here. Is there a difference between complex PTSD and BPD? No, I'm not repeating myself, I'm repeating Lois, that's right. Yes, of course there is. And as she said, 10 to 30% of people with BPD have not experienced trauma. And I think there's a marker, another marker. Zanarini showed in a very early paper, a third of people with BPD have levels of dissociation within the normal range. Now, in this case, dissociation is a marker of trauma, in my view. And in that paper, Zanarini showed third BPD people have normal levels of dissociation, another third have elevated levels on the dissociative experience scale between 10 and 30, and the top third have dissociation levels on the DES over 30, which is within the pathological range of dissociation and accompanied often by a definitive diagnosis of a dissociative disorder. It's very important, I think, finding that has been made. Well, the dangers of renaming BPD. As we all know, there's been a huge call to rename BPD as complex PTSD. If it were to be reclassified, there's a danger that trauma only becomes the focus of treatment. And that has been so well described and illuminated, really, by Lois. But I think there's a really, how can I put this? A vivid example of this. Babette Rothschild, who's a trauma specialist, as you will all know, writes about a huge number of, how many minutes have I got? 5 minutes. Okay, I better hurry. She writes about people with PTSD sent to psychologists for a limited number of sessions. This is in the US, but I think sadly it happens here too, with what's supported by Medicare. And a lot of the clinicians seem to leap straight into trying to revise or review or work through, process, I think is a better word, the trauma memories. Now that is a disaster. That is a disaster because you'll just re-traumatise the patient if you go straight to reprocessing trauma memories. And I think that's the kind of thing that can happen. That if BPD were to be renamed complex PTSD, then the trauma would become the focus at great, in my view, great cost. Another question. This is controversial. Has the mental health profession adopted the mantra of trauma-informed care at the cost of deeper reflection on the meaning of the traumatic event to the person who's suffered it? I'm all for trauma-informed care. It's terribly important that we consider trauma in the lives of the people we see, absolutely. But we should also consider what is their personality development, what are their strengths, what are their skills, what are their other co-occurring disorders that they may have, because we need, as Lois has said, to treat all of them. And I think mantras can so easily obscure thought. We can get stuck on a mantra and get in the way of individualised formulation-based approaches to assessment and treatment. So could forgetting of the 1900s happen again? Absolutely, it would happen again. It could happen again because the defences that led to the forgetting were used by people just like ourselves. Remembering has only occurred when sufficient force has been brought to bear on societal attitudes and all the politicians of the day, and that's been very striking to me in my looking at the history of trauma. It's striking how it was the Vietnam vets with their refusal to be silent who lobbied clinicians and lobbied politicians, and of course the rise of feminism in the 70s and 80s functioned in the same way. The women now had a voice. Is forgetting happening right here, right now? I think it is. I think many in Australia have turned a blind eye to the trauma suffered by the refugees who come here. Political action, as we've seen, requires societal support, and sadly, political action is not available on either side of the bench, if you like. But as mental health professionals, what we can do, like Gardner in World War I, is carefully document the effects of trauma on individuals, all individuals, not just refugees that we see, and publish them. Gardner had to wait until World War II to publish his book. But in time, it was pivotal, as we've seen, to the DSM-3 criteria for PTSD. 40 years later, what matters is the impact and meaning of traumatic events for those who experience them, and ensuring a personalised approach to their care which looks at and thinks about the whole picture. And remembering that those who fail to learn from history are doomed to repeat it. Thank you.
Thank you, Joe. That was an excellent presentation. We do have some time for questions. So let me go for the first question. The first question is, could borderline personality disorder be conceptualized as an accumulation of trauma in its own right? That is, the impacts of being traumatic.
So could it be conceptualized as a accumulation of trauma?
Yes.
In its own right.
That's right.
That's a very interesting question. I don't think that in itself would do the trick, if you like, because so much of BPD depends on inborn temperament. What percentage will vary with individual people who have BPD, but an inborn temperament, highly sensitive, tending to negativity in affective responses, is pivotal to people with BPD. And I think that's one major difference too, perhaps with complex PTSD, because what we need is long-term prospective studies really from birth. I don't know how you could do them, but I think that inborn temperament is likely to be different in many people. However, we do, as Lois has said, need to acknowledge the extent of trauma in people with BPD. And I think a major difference between complex PTSD and BPD is the number of people with BPD who have disorganised attachment from infancy and onwards, and the effects of disorganised attachment. Because it's disorganised attachment that, as you all know, means that the parent, the caregiver, is at one and the same time a source of fear and a source of longed-for comfort. And splitting and the primitive defences arise from that dilemma for the baby. I'm going on much too long in my answer to this question, but I think it's so important to know that that in itself is a trauma to the child, but we cannot blame the parent for that, because there's such a interaction between an infant temperament and caregiver response. And we have to think about the impact of a very sensitive, easily upset, distressed, hard to feed, hard to settle baby on a vulnerable mother who may herself be depressed, who may herself have borderline personality disorder. As we know, there are transgenerational transmissions very often of this. And how does that impact? Lois said it, didn't she? The tendency to withdraw on the part of the other. And I know she wasn't talking about infants, she was talking about adolescents, but it happens right from birth. And I think we have to say, well, what do we call trauma? Yeah, it has a traumatic effect on the infant, but it's not about blaming the parent, it's about helping these people. I hope that answers the question.
The other corollary to that question is the experience of borderline personality disorder, having to go through the distressing symptoms of borderline personality disorder in itself traumatic.
Yeah. Oh, exactly. Because as Zanarini so brilliantly described in a paper, I think it was called The Pain of Being Borderline. The pain of being borderline is like being born without a skin. Without a skin. Can you imagine being born without a skin? So that everything that affects you, your skin, in your mind, is traumatic, is painful. And I think, and then the person with BPD too often is rejected by, they go to ED, they receive terrible responses. How awful is that people who most need the help of the people they go to, so with such sometimes hope, but increasingly, repeatedly, despair, because they expect not to be helped, that's the tragedy. So I think that's a very important corollary, Sathya.
Thank you, Joe. I think we run out of time for further questions. So please join me in giving a big applause. Thank you, Joe.